Hi, this is Ellie Fishman, and welcome to our YouTube Wednesday chit chat. And for a couple of years, or many years now, we've done Facebook Live, and now we're doing YouTube Live. Remember, YouTube is a very big place for CTisus. We have all of our lectures there, the cases, we have tons of material, but we are going to take advantage of the newest technology that YouTube has to offer to allow us to get together with you and get any comments and present information. And what we're going to do is do basically like a 5 minute thing, not a 15 minute or 20 minute. I will just give you a little bit of heads up in the beginning. I'll talk about the fact that we are working on new lectures. We're working on 7 new lectures, 4 or 5 parts each. They're going to start appearing next month. So we have a lot of really good material showing up. I was putting these talks together in part for the University of Pennsylvania course in Martha's Vineyard at the end of this month. I expanded them all, added stuff, and so it should be great. But what I'm going to talk about on these YouTube, as I mentioned last week, is misdiagnosis. And I give lectures on misdiagnosis. We all make misdiagnoses. The question is, what can we learn and what are the errors? I think all of us have concluded that if you're aware of the errors, then you will make less of them. Brooke Jeffrey, who was retired, I can't believe it, from Stanford, who was the best of the best, always made the point that he had a checklist for trauma. Brooke and Mike Federley wrote the key articles, the textbook on trauma when they were at the San Francisco General 1,000 years ago. But Brooke said his checklist really was the things that he had missed. And the other things were easy. The things he got right all the time were easy. It was the things he missed. A bleed in the mesentery, a tear of a vessel, things like that. So we're going to try to focus on the things people make mistakes on. So this is not going to be a complete list because I only have 5 minutes. So let's talk about the chest. And let me give you 3 or 4 mistakes that we commonly see. Number 1, the patient has a aortic dissection type A involving the ascending aorta. We know this type A, ascending aorta, type B, post-left subclavian. We're not going to get into that. What I've seen happen many times, patients present with chest pain. So the diagnosis is rule out dissection, rule out PE, rule out anything. But what happens is the patient breathes. It's typically not a gated study. And they breathe, and it looks like a linear line, and it's read as dissection. Patients I've seen have come to the hospital, go to the OR, and before they crack the chest, they do echo, and they find nothing. Then we get a repeat CT, and it's negative. You need to be very careful when you call a type A dissection. Obviously, it happens, and sometimes it's really easy to make the diagnosis. But when you have motion, linear lines, and you call that a dissection, here's how you avoid the error. If you're uncertain, first of all, repeat the study with a gated acquisition. That's 1. Number 2, what typically happens, these linear lines that look like dissections typically go beyond the aorta and often go into the pulmonary artery. When you see what looks like a dissection and it goes beyond the vessel and particularly into the pulmonary artery, you know that's artifact. That's not a dissection. And if you're looking at multiple slices, dissections kind of go in the same line or pretty close, so you follow them up. If the dissection is one line, then it's angled 20 more degrees and then 20 degrees. Okay, that's not a dissection. That's just motion simulating a dissection. And I've seen that mistake made numerous times. Do not make that mistake. Number 2, pulmonary embolism. I could spend an hour talking about mistakes in pulmonary embolism, but let me pick on one of them, which is the misdiagnosis of PE. Now, I can tell you misdiagnosis of PE is related to poor technique, poor bolus, looking at thick sections rather than thin. But I'm going to talk not about the rule out PE. I'm going to talk about the PE that's often an oncology patient. Remember, oncology patients, 5% of incidental PEs, but it's an abdominal CT, but you got this much chest. And you give a quick glance, make sure there's no lung metastasis because it is an oncology patient, or even a non-oncology patient. What you have to do is look carefully at the lowest sections, particularly with the thin sections. Make certain you're not missing an incidental PE. Particularly in oncology patients, but in all patients, look very carefully. Oncology is a much higher percentage. Patients are often asymptomatic at time of the study. They're getting an abdominal CT. There was an article by Charlie White that mentioned this a number of years ago. So when you're doing abdominal CT, look very carefully. Make sure you're not missing a lung nodule, obviously, but make sure you're not missing a pulmonary embolism. I'll come back a different time to talk more about PEs, the timing of the contrast delivery, the motion-related artifacts, when the contrast is not homogeneous in the vessels, things like that. We'll talk about that. The third thing I'll mention will be looking for pulmonary nodules. You want to be very careful. Now, I think all of us have the same experience. If you look hard enough at a thin section CT, there's almost nobody who doesn't have a nodule. I think there's a big challenge where people are calling all these 3 millimeter nodules. It's particularly the residents, and they'll say 3 millimeter nodule with device clinical correlation or follow-up. I think we're going to have to get past those 3 millimeter nodules or 4 millimeter nodules. I'm not sure we even should mention them. I guess we have to mention them, but they're no clinical significance, okay? Otherwise, you're going to be pursuing an incredible number of patients, giving incredible radiation doses over time because the nodules are not going to change. And you're going to be following up these patients time and time again. Now, I also have a piece of paper here. And so I wouldn't forget, I think I wrote down something else. What else did I say? Oh, hypoinflation. I often read cases or see cases where patients are felt to have early infiltrates, particularly in the COVID era where everyone's looking for ground glass infiltrates or crazy paving and mosaic patterns. We want to be really careful. When the patient has increased markings in both bases, the patient likely is hypoinflated. Yes, you can have bilateral pneumonias and bilateral aspiration and COVID, both lungs, but you want to be very careful. When the upper 2/3 look good and the bottom looks just like increased markings, you might want to say that there's increased markings at the bases, likely due to hypoinflation. Don't say revise clinical correlation, probably don't say that. Don't say repeat the study because they will. So you want to be very careful. Don't overcall hypoinflation. I see that happen all the time. Those are 4 interesting things to think about. Don't overcall aortic dissections. Type A, be careful. B, don't miss the PE at the lung bases. 3, look carefully at lung nodules. Don't overcall the presence of nodules. And 4, don't overcall hypoinflation of the lung as suspected infiltrate. And my time is up. I said 5 minutes. I would do 5 minutes. I did 8 minutes. I apologize in advance for 8 minutes. And any comments, just let us know. If not, we look forward to seeing you next time. And have a great day.